Yep.
Still going to ask everyone to at the top of their, you don't have to shout, but volume in the room, but it's still quiet up here. So we'll try to project. I'm going to ask Dr. Carden to enter his testimony into the record because members of the public here. So apologies, ask you to read. Before we do that, I want to go back to your objection. After discussing with our counsel, however, we will issue a document that will follow the appropriate presentation so that you can see the sources of that data and
First, just can people hear adequately now? Speak at this level. Good morning, Dr. Gifford, members of the OHS staff. James Carden, Clinical Integration Officer at Hartford Healthcare. I adopt my pre-filing testimony. We appreciate the opportunity to share Hartford Healthcare strategies to transform the delivery of healthcare, specifically as it relates to our additional need for healthcare. Our path to transformation is to ensure there's timely access to both affordable and equitable. This enables MidState and Hartford to participate meaningfully in this space. MidState is an excellent demonstration of our full transformation strategy. Historically, it was a community hospital without the capabilities to provide more care that a hospital should be utilized for, has been transformed into a center of excellence, allowing us to provide services usually performed in a tertiary or quaternary care hospital. This includes the development of the Orthopedic Institute, and enhanced oncology care, cardiovascular care, including arrhythmia interventions for complex arrhythmia management and comprehensive vascular surgery. All performed in the local community where people want to receive care and at a level of quality that is world class. Important for us, though, not just develop these services at the hospital, but a line of sight to lowering the total cost of care, and therefore it is important that as we maximize mid-state capacity to provide a higher level of care, we were simultaneously developing and deploying ambulatory care sites that provide lower cost sites of care, the procedures that could and should be done in a less complex environment and in a setting that is both lower cost. I'd like to spend a few minutes on each of those four key pillars and provide some examples of the progress. Excellence, which is foundational to the transformation. We're committed to measure, manage our quality, and look for external validation for the progress. Extremely proud of rating. This an measures that evaluate both quality and safety within their hospitals. Healthcare is achieved leapfrog A across all of our 7 acute care hospitals. 3 other systems of our size have achieved that rating in the nation, and MidState has achieved leapfrog A, which is only 1 or 2 hospitals. 30% of leapfrog A, I'm sorry, 30% of hospitals in the nation get an A rating. I misstated that. That's not a leapfrog. That's 1 of 2. That was our CMS star rating. 1 of 2 hospitals received a 5-star CMS rating in the state. In addition, focus on reducing harm and health and hospital-acquired conditions. We reduced those to where we have not received any from CMS in the last 2 years. Patient experience score through HCAHPS, we received a 4-star rating since 2020, above both national average and state average. Orthopedics has a 5-star rating from CMS for hip, knee, and spine surgery. National Association of Orthopedic Nursing has seen the Excellence Award, and we received advanced certification in spine surgery, which is the first program that hip and knee fracture surgery as well as shoulder. All of this is really being developed so that we can provide that timely access in the community. Care and no need. Those include the capabilities we just went through, neurospine, vascular surgery, cardiovascular technology, and all of that reflected in the complexity of care we're seeing within the community. We've seen an increase in our case mix index, a measure of that, 31%. In addition, our commitment to the ambulatory environment, including ambulatory surgery centers, urgent care centers, and continue alignment with our primary care initiative to provide access in the community. All of that is in a concerted attempt to lower total cost of care and make care more affordable. Orthopedic surgeries at MidState increased from 2017 to 2023. 1,600 cases done in the care facility, 5,200 cases in 2017. 20% of them were in HOPD, so an outpatient hospital designation, which is lower cost. In 2023, 80% of the increased cases are being done in outpatient location, which is importantly, the move to ambulatory surgery centers was critical. These are not at hospital rates. In 2021, we did 3,600 cases. In 2023, 9,400, an increase of orthopedic surgery moved from inpatient to ambulatory setting at the same quality and performance that we expect. In addition, we just this week had dental surgeons move their cases from hospitals into the ASCs and we continue to expand the kind of services that we can perform in the centers. And from a testosterone perspective, we've done in the outpatient hospital setting. We've moved into the ambulatory again surgery centers. 15,721 is now at 26,000, a 66% increase. Urgent care visits are an opportunity to try and enhance the emergency departments of low-level visits has increased from 2018 to 2023, 25,000 visits in a year, 79,000 visits in a year, 205% increase. And that indeed has been reflected in a reduction in ED visits by 18% over that time frame. 20% of our total visits used to be level 1 and level 2. That's now been reduced to 15.7%. So as we've been able to get more opportunity and access to the care and more convenient that way, that people not having to go to expensive departments, see that care at an urgent care center at a substantial lower cost. This is in addition to all of the other measures we're looking at in terms of trying to control avoidable utilization, skilled nursing facility utilization, readmissions back into the hospital, conditions that reducing complications, reduces hospital utilization. Broad rating is a measure of many of these measures. But importantly, preventive care is a foundation for managing risk conditions, hypertension, diabetes, end-stage disease that often results in hospitalization or additional care. We've had a focused effort around our ability to manage both hypertension and diabetes, and segmenting that by at-risk communities versus the general population to ensure that we are addressing the inequity. We managed 10,000 folks that were responsible for hypertension. 75% of them are at goal at the end of the most recent year. And diabetes, over we're seeing 78% patients with their diabetes adequately managed. And as we look at disparities, where we see disparities in diabetes management in the at-risk zip codes, we are making good progress. Targeted Lastly, or next is really on equity. We've got a focused effort across our healthcare, developing a center that allows us to look at and measure the disparities that we see both in the workforce and the communities that we serve in terms of providing care. We understand that partnerships with community organization and community leaders is an essential part for us to decrease those disparities and working with champions is a focus. Our resource groups participate in the Fair Chance program, focused on develop and making sure that we are adequately capturing adequate and race, ethnicity, language data, as well as social determinants. And we continue to deploy our neighborhood health program, which we know about testing and vaccine, bring community services from social services to medical care into the community and access problems that they have. Lastly, in accordance with alignment and our payment model to ensure that we are able to take advantage of the system of care that we built. We participate in full risk for Medicare Advantage in two models. One are APN Connecticut, where we have about 5,000 members in full risk, as well as our joint venture partners here plan with about 8,000 members. And with those folks, we are continuing to focus on quality ratings. This is a star rating for Medicare Advantage plans nationally. These measures and measures to ensure we are seeing quality of care in the environment. The affordability measures that we want to ensure centers of focus with utilization, SNF transitions to stay within the SNFs, skilled nursing facility, and a CHF program to manage that to ensure that we are adequately care for people. Lastly, but importantly, the focus effort in developing the center of excellence around is participated now for 6 years in the CJR program through CMMI. This was a program that focuses on hospital outpatient replacement. Some dramatic improvements across multiple measures, demonstrating that we focus in full alignment with providers and the staff to see significant improvement in overall measures. As an example, our quality score when we started the program was 4.420. By the 6th year, we are at 18. Application rate was 1.40. By 10%. In addition, skilled nursing facility utilization was 87% this year, down to 5.3%. Our last performance year, home care dropped from 88.9 to 28.6. Inpatient length of stay went from 3.8 to hospital outpatient. 5% of our cases were done in hospital outpatient. The program is now 77.6. All of this work resulted in being recognized as the destination for patients with DDoS. Police, Finkelstein, and genetic editing these issues in greater detail. It is important to understand that we've exceeded our space capacity to provide the care that patients in the community expect and deserve. I respectfully request that you approve this application. I'm happy to answer any questions. Thank you for letting me hear.
Good morning. Good morning, Executive Director Gifford and members of the OHS staff. My name is Jeff Finkelstein, and I'm Vice President of Medical Affairs of the Central Region of Heartland Healthcare. I oversee clinical affairs at MidState Medical Center and the Hospital of Central Connecticut. And I adopt my pre-filed testimony. Pause. Can you hear me?
Have excellent audio according to someone.
Good job.
My colleagues know that.
I think the issue now is us who are having difficulty with it, so we're going to have to speak with it.
Thank you for this opportunity to speak in support of MidState's request for CON approval to add inpatient beds at the Marion campus. Based on my experience in both clinical and administrative positions at MidState and within the Hartford healthcare system, I am in a unique position to assist OHS with understanding the need for additional inpatient beds at MidState, and benefits to patients of increasing licensed bed capacity at the hospital. Over the course of the last 20 years, I have held various positions within the Hartford healthcare system, including the first medical director of the Hartford Healthcare Go Health Urgent Care, chief of the Department of Emergency Medicine at Hartford Hospital, as well as chief of the Department of Emergency Medicine at the Hospital Central Connecticut. My testimony today will focus on several issues. First, I will discuss inpatient capacity issues at MidState, the bed need methodology that was used to arrive at the need for additional licensed beds. My colleague, Jeanette Edwards, Vice President of Operations for the Central Region of Hartford Healthcare, is here with me today to answer any questions you have about our bed need calculation. I will also provide OHS with additional details regarding the high quality of medical care provided to patients at MidState. Colleague, Dr. Cardin, mentioned several of the accolades received by the hospital in recent years, all of which show that MidState is a high-performing hospital where patients receive safe and effective care. This is the primary reason the hospital is as busy as it is, both in the emergency department and in the inpatient units, and why additional bed capacity is needed. Finally, I will testify about 30-day readmissions at MidState so that OHS has a better understanding of how the hospital's performance has improved on this measure, what we have done to realize improvement in readmission rates, and which readmissions are not necessarily within our control. It is important to note that MidState performs well on readmission measures. Readmissions we do see, to the extent that they can be affected, would not avoid the need for additional inpatient bed capacity at the hospital. Let's talk about capacity issues at MidState. Our deliberate focus on expanding service offering, striving towards enhanced access, affordability, equity, and excellence has enabled us to provide patients with better access to higher quality care in the most affordable and cost-effective setting. As a result, demand at the hospital continues to increase, and additional inpatient beds are needed to meet that demand. MidState's inpatient census has been increasing steadily for many years, further straining capacity as patient demand continues to grow. MidState has seen a significant increase in inpatient discharges, observation cases, surgical volume, emergency department visits, and extended stay patients over the last several years. In fact, almost every hospital in the country, the hospital is currently experiencing census very near its licensed medical surgical bed capacity, resulting in patients boarding in the emergency department while awaiting admission. Currently, there is more demand than there is available inpatient bed capacity. Between fiscal year 2020 and fiscal year 2023, patient discharges or transitions increased by 17%, 1,510 patients. The hospital currently has 131 licensed staff available adult medical surgical beds. FY 2022, we were operating at 84% of available capacity. This puts the hospital well above the industry target of 80% occupancy for community hospitals. As the care delivery model for orthopedic patients has evolved, MidState has also experienced an increase in extended stay patients, outpatients who are placed in an inpatient unit for post-procedure care, extended recovery time, or recovery from a weekend or after-hours procedure. In just 1 year period of time between fiscal year 2022 and fiscal year 2023, extended stay patients increased 13%, from 3,036 to 3,431 patients, an increase of 395. Most extended stay patients at MidState are associated with the Connecticut Orthopedic Institute and have an average length of stay of approximately 2 days. These patients reside in an inpatient bed during their extended stay, therefore making it unavailable for other inpatient admissions. The Connecticut Orthopedic Institute patients account for more than 6,000 additional patient days not included in the occupancy rate calculation used above. If they are considered patient occupancy rate, occupancy rate of 80%. Health and Human Services hospital has a ability to respond to unforeseen fluctuations or surges and as experienced during the recent COVID-19 pandemic. We really want to admit our patients as quickly as possible to avoid delays in care and corresponding increasing costs. In addition to the inability to respond to insert situations, strained inpatient bed capacity also results in an increase in admitted patients boarding in the emergency department as they wait for a bed to become available. As my colleague, Dr. Dan Engelberg, will discuss, boarding is a significant issue at MidState. The practice can be detrimental from a quality and safety perspective of those patients being boarded, as well as other ED patients. ED staff burnout and attrition as a result of ED boarding is also a real concern. MidState has submitted this request for approval to add licensed beds based on current capacity constraints and anticipation of continued growth in volume. There's sufficient demand in the MidState service area to support these beds. Beds are needed to treat individuals who choose to obtain their care at MidState, who need the specialized services offered at MidState, and whose treating physicians do not have privileges elsewhere. The demand for beds at MidState also exists independent of any other hospital's available bed capacity. This includes available beds at the Hospital Central Connecticut, which serve a different community and for which future plans for use exist. Additional beds will allow the hospital to continue to provide timely access to high quality, affordable care for patients, including those admitted through the emergency department. A bed need analysis. Analyzing bed need, MidState chose a model that is sensitive to the unique circumstances at the hospital that most accurately estimates projected bed use. Based on existing bed configurations at the hospital, actual patient days, and average daily census, target occupancy rates by unit, and includes a range of projected volume growth based on historic utilization and other factors. There's no one specific methodology to determine the optimal number of beds required at a hospital, and differing models can be used to estimate this number in different contexts. We understand that the statewide healthcare facilities and services plan includes a population-based model for calculating hospital bed need. However, this model has many limitations. In this case, is not appropriate model to estimate MidState's bed need given the hospital's unique circumstances. The population that OHS proposes to use does not accurately reflect MidState's patient population. The weighted average daily census that OHS uses covers several years of the COVID-19 pandemic and does not factor in the tremendous growth in demand for inpatient services that MidState has experienced with establishment of the Connecticut Orthopedic Institute, other quality and service enhancements. And the model does not account for present and projected future growth in demand, independent of any growth or lack thereof in New Haven County population. Significant increase in extended stay patients the hospital is experiencing. It's simply and entirely the wrong model for MidState. Statewide healthcare facilities and services plan does, however, allow OHS to consider other factors when reviewing a request for additional inpatient bed capacity. Each of these factors should be considered here because each factor supports the need for an increase in licensed beds at MidState. These factors include observation beds, which MidState has experienced in addition to the significant volume of extended stay patients we've mentioned. Average weekday occupancy rate or census for two separate and distinct periods of 30 calendar days for the most recent 12-month period at or above 80% of total licensed bed, which MidState experienced in fiscal year 2023. Particular innovations, changes in care delivery models or modalities, resources, including physical resources and building facilities, needed to treat specific diseases or conditions. Criteria that appears custom built for the Connecticut Orthopedic Institute changes is brought to MidState. And quality or patient safety concern. We would expect to experience more frequently as a result of inpatient capacity strains and higher levels of ED. Additional bed capacity will improve the quality of patient care by avoiding delays in treatment caused by ED. Improve patient experience by reducing time spent in the emergency department and reduce strain on emergency department and inpatient resources. These beds will also reduce ED length of stay and foster more cost-effective care. The added benefit of the additional bed capacity is the ability to cohort oncology patients in a single physical unit. The unit will have cancer-trained clinical staff and be close proximity to the hospital's brand new pharmacy. This will free up bed capacity currently used by oncology patients for other medical surgical admissions. Notably, the additional medical surgical beds will be available to all patients, including Medicaid patients, who comprise 17.6% of the hospital's payer mix. Quality of care. As Dr. Cardin mentioned, MidState is an award-winning institution for quality of care and patient safety. I would like to touch briefly on a few of MidState's recognitions that are particularly noteworthy: quality, safety, and patient experience standpoint. First, MidState, along with all the other Hartford healthcare hospitals, was awarded a Leapfrog Hospital Safety Grade of A. As you know, Leapfrog is a watchdog organization committed to transparency, the gold standard for evaluating the quality and safety of hospital care. MidState has received an A grade 3 of the last 4 years. We are incredibly proud of this accomplishment. MidState also received a 5-star overall hospital quality star rating from CMS. One of only 3 hospitals in the state of Connecticut, 483 hospitals nationwide to receive this top rating. MidState has received many other accolades, both national and regional, which are detailed in my pre-filed testimony. The Connecticut Orthopedic Institute in particular has achieved advanced certification from the Joint Commission and numerous other recognitions related to patient care, safety, and patient experience. There's no doubt that MidState provides exceptional quality care to all patients, from those needing community-based hospital and emergency care to those seeking highly specialized orthopedic and other treatment in our hospital. Granting of the CON request to add additional licensed beds will ensure that every patient who presents to MidState Medical Center in need of our inpatient services will receive those services in a timely manner, ensuring the best possible health outcome. 30-day readmission. Finally, I would like to touch briefly on the issue of 30-day readmissions at MidState, given OHS's request to provide information regarding efforts to optimize the use of our current inpatient capacity by reducing these admissions. First, it's important to note that MidState does very well with respect to readmission. There have been steady and substantial improvements in 30-day readmissions hospital-wide in fiscal year 19 and fiscal year 22. Looking at readmissions data just for the Medicare program for the time period spanning July of 19 through June of 2022, the hospital outperformed its peer group in 3 of the 5-day, 30-day, all-cause, unplanned, risk-standardized readmission measures. Specifically, MidState performed better than its peers on readmissions resulting from acute myocardial infarction, heart failure, and pneumonia. In areas where MidState did not outperform its peers or where expected readmission rates were lower than predicted admission rates, the differences were not significant enough to suggest that MidState is an outlier when it comes to 30-day. Reductions in readmissions at MidState are due to a number of factors, including but not limited to improved efforts in our progression rounds for entire clinical care teams, medication reconciliation, care coordination utilizing transition care coordinators, daily family communication during hospitalization, and emphasis on establishing follow-up appointments within 72 hours of transition. 30-day all-cause readmissions have decreased by 35%, 176 readmissions. Readmissions over the expected rate have decreased from 85 to 24 for by 72%. Readmissions for individuals over 65 years of age have also declined by 38%. The financial penalty against MidState has decreased substantially from fiscal year 19 to fiscal year 23. Despite MidState's efforts to educate and inform patients of the need for follow-up care, the system's efforts to coordinate downstream care post-hospitalization, there are too few available post-acute resources in the community MidState serves, such as skilled nursing facilities and home care, to address all of our patient care issues before they reach the point where readmission is necessary. Also, every hospital contends with issues of patient noncompliance that increase the likelihood of readmission, such as failing to attend follow-up appointments and follow-up medical and to follow medical recommendations, as well as clinical complications that arise after discharge through no fault of the hospital. MidState is committed to improving 30-day readmissions and continually improving the care we provide to patients. However, the hospital does not have the ability to eliminate readmissions altogether. The readmissions we are seeing are consistent with national averages and do not impact MidState's need for additional bed capacity. Thank you again for this opportunity to testify in support of MidState's CON request for additional inpatient beds. Our exemplary quality of care and commitment to excellence make MidState the ideal hospital at which to approve additional licensed beds. These beds, which are needed to address critical capacity constraints, will be used to ensure that all patients admitted to the hospital, as well as patients in our emergency department, have access to high quality, safe, timely care, and best health outcomes. For these reasons, I respectfully request that you approve our CON request. I'm available to answer any questions that you may have.
Dr. Gifford, members of the OHS staff, good morning. My name is Daniel Engelberg. I'm to adopt my pre-filed testimony. I'm the director of the emergency department at MidState Medical Center. I'm also the director of EMS, medical control department. I'm also a working clinician in the emergency department, so I get to deal with what it does to our community, our patients. I want to thank you for this opportunity to speak in support of MidState's CON application for the addition of licensed beds at the center. Our hospital experiences overcrowding in the emergency and patient boarding due to lack of sufficient inpatient capacity. Proposed additional beds will help address this problem, thereby improve patient care and flow. My testimony today will focus on increasing the number of patient beds on the increasing number of patients that are actively boarding in the emergency department at MidState Medical Center while awaiting inpatient care. I'll also discuss in further detail, as evidenced in literature and practical experience, that ED boarding is detrimental to the quality of care and patient safety, and it also increases healthcare costs. I'm going to discuss MidState's plan to reduce avoidable ED visits and pleasant ED overcrowding. While these efforts enhance quality and affordability of the ED care, they do not obviate the need for additional patient bed capacity at MidState. Additional bed capacity will significantly reduce ED boarding, ensure that all patients that are admitted through the emergency department receive timely, focused, and coordinated care on inpatient units. As my colleagues have mentioned, enhancements in access to services and improvements in the quality have made MidState Medical Center a destination for many services, including emergency services. We focused on building relationships with first responders and the community at large. We've improved communication, and we've built trust. As a result, the number of patients that have been coming to MidState Medical Center has been increasing over the past few years. ED visits have increased steadily since fiscal year 2020, from 22% during this time to about 8,400 visits. MidState ED had approximately 46,000 patient visits in fiscal year 2023. More than 30,000 of these were coded as level 4 or 5 visits, which are the most complex visits that come to an emergency department. Our ED is a high volume ED. Despite our issues with boarding, to provide the highest quality and most efficient care possible. Median time from ED arrival to ED departure for discharged patients is below the national average, as is the percentage of individuals who leave MidState without being seen. That people that are coming and are being discharged from the emergency department receive timely quality care. We're able to turn them around and see the vast majority of patients that show up. I see left without being seen as a real detriment to emergency care, and specifically. As busy as MidState has been, the hospital has similar growth in volume across all service lines and inpatient units. Inpatient bed capacity has become strained with fiscal year occupancy rates reaching 84 to 90%, with and without consideration of extended stay patients. This has resulted in an increased number of patients that board the emergency department, particularly in hallway beds. JCO has identified boarding as a patient safety risk and practice that should not exceed 4 hours for any given patient. I'll tell you, I believe any time is too long. Boarding impairs access to timely emergency care, results in care delays for patients waiting to be admitted. Those patients clinicians are actively evaluating and treating. It also comprises care through necessary use of hallways and other suboptimal areas with limited resources. Finally, some patients give up and leave the ED without being seen at all. All of these downstream impacts from ED boarding drive up the cost of care for patients and for payers. ED boarding also negatively impacts emergency physicians, physician assistants, nurse practitioners, nurses, ancillary, clinical, and non-clinical staff. Our teams are designed to deliver high quality episodic care and are not equipped to manage inpatient patients in the emergency department for long periods of time. Because boarding degrades the ED work environment, the ED regularly loses staff. Replacement of clinical staff in the emergency department consumes significant financial resources and disrupts the continuity of clinical practice. Due to the increase in demand, I and my colleagues have described, the number of patients who spend 4 hours or more in the emergency department prior to being assigned an inpatient bed has increased significantly from 1,610 patients in fiscal year 2020 to 3,704 patients in fiscal year 2020. From March 1st, 2023 to May 31st, 2023, 198 admitted general medicine patients were discharged directly from the emergency department. It's over a 3-month span. These are patients who should have been admitted to the hospital, who should have had an inpatient bed, who were boarding in the emergency department for a long enough time that they were discharged directly from the ED. Not transferred to an inpatient unit, and thus the strain on inpatient capacity is not sustainable, it's suboptimal for quality, patient safety, effective. In an effort to mitigate ED boarding, alleviate the strain on ED resources, accommodate increasing volume, we open temporary surge spaces. These surge spaces provide some relief to the ED, but are only a temporary solution and cannot be used as a long-term solution to address boarding. Transferring patients to other hospitals does not solve the problem either. MidState does transfer patients to Hospital of Central Connecticut, which is our nearest hospital, or to other hospitals in emergency situations when deemed appropriate. Generally, however, when patients and their support persons are asked if they will agree to be transferred, specifically to mitigate inpatient boarding, they often decline, citing reasons such as continuity of care, distance from their homes, or the fact that they've shown up at MidState and want to be admitted specifically to MidState for the high quality of care that we are doing. Patient preference is always respected. Southington campus of HOCC has very limited capacity. They don't provide the level of services that are required for traditional patients, orthopedic patients, or generally other patients that we would consider transferring. Meaning it's not an option for most patient transfers. With the addition of 16 inpatient beds at MidState, overall occupancy, including extended stay patients, will drop to 80%. This is the industry benchmark for community hospitals. The addition of 16 inpatient beds is a cost-effective solution to help mitigate ED. It will improve patient flow through the ED and provide more rapid access to inpatient treatment. Improved flow will also reduce ED overcrowding, facilitate quicker access for patients, emergency evaluation, treatment, and stabilization. It will also lead to less clinical death. We talked about reducing avoidable ED visits. I'd like to focus on this for a moment. OHS has raised the issue of reducing inappropriate utilization of the ED and lessen overcrowding. While MidState and HHC are continuously working to reduce avoidable ED visits and ensure that patients are receiving care in the most appropriate and cost-effective setting, reducing ED visits has no real impact on the issue of ED boarding and the need for additional inpatient beds. To be clear, patients who present to the ED and require inpatient admission are not avoidable. They have conditions that are so sufficiently severe that they require inpatient optimization and admission. MidState and HHC has made efforts to ensure that patients receive clinically appropriate care in the right setting, while still complying with laws such as EMTALA that include EDs turning away patients who present for care. Expanding access to preventative and primary care is essential for improving the health of communities and for reducing ED overutilization. ED access to both urgent care and primary care services significantly reduces the number of avoidable encounters. Urgent care centers play an important role in achieving the goal in reducing emergency department utilization and have significantly reduced cost expenditures and out-of-pocket costs for patients. As Dr. Carden mentioned, urgent care volume in the MidState PSA has grown steadily since fiscal year 2018 and has increased by about 205% or more than 50,000 visits to urgent cares over a 5-year period. Still, our volumes are rising at the emergency. Level 1 and level 2 visits at MidState, the lowest coded level visits, have declined by 18% fiscal year 2018. And the percentage of total visits that were level 1 and level 2 have decreased from 20.2% in fiscal year 2018 to 15.7% in fiscal year 2023. We are getting sicker patients. Sicker patients who need to be admitted. Although our MidState ED volume has continued to grow, the result of an aging population, prevalence of chronic conditions, community, lower acuity volume has transitioned these lower costs to more accessible urgent care centers. MidState ED staff, as well as MediQuick staff, work with patients to ensure that they have an appropriate primary care provider, that they have appropriate specialty care follow-up, and that we can provide any necessary services to avoid any avoidable ED. These measures help lessen the likelihood of avoidable ED visits in the future by connecting patients with PCPs and other specialty services. The hospital's efforts to reduce inappropriate use of the ED have been successful, as it is shown by significant increases in the urgent care volumes, which I mentioned earlier. Use of urgent care is just one of the strategies that we have utilized to manage that appropriate care is managed in the highest quality, affordable setting. Thank you again for this opportunity to speak in support of the state's CON for the addition of license. Approval of this proposal is critical to solving the significant issue of emergency department boarding at the State Medical Center, which is adversely impacting access, quality, and affordability for patients in our community that are in need of emergency medical service. I urge you to approve the CON that MidState can continue to provide the highest quality care for all patients in our services. I'm available for any questions that you have. Thank you.
It might make sense to take a break. All right, so we'll come back at 11:30 and we will proceed with questions from OHS. Capacity. Earlier, we had some testimony from the witnesses. Pasco, did you have any questions for them before? This question?
No direct questions, but I'd like to reserve the right to redirect after your questions, if I may.
So we're going to start with OHS questions. I don't know.
In the pre-filed testimony, the applicant discusses if it intends to cohort oncology beds across the hospital. The applicant cohort oncology patients with additional beds.
We already cohort oncology patients as much as we can in the space. They're gonna be in a bed somewhere, and we try to put them all together, currently on pavilion B. But it's not big enough, and that increases our boarding in our ED.
So you've already cohort them currently
As best we
as
can,
best
yes.
as you can. And how would it assist with cohort?
We would move the oncology from the currently where we some but not all, the new pavilion F, cohort all of them, which is a much better space because it's close to the pharmacy where we get the chemotherapy. So, we have enough space to cohort all, not just some. The beds that they vacate would be open to other med-surg patients. That's-
The applicant. So 100 and,
I would state your name.
Sure, I'm Jeanette Edwards, I'm the Vice President of Operations at MidState Medical Center. So 131 beds, that represents all of our med-surg beds available on our intensive care unit on the critical care. That's on the state. So those are the beds that are in question today, those 131 beds that we are out of space in those units. So the additional beds that make up the 144, those are used for our maternity care today. Those are not considered surge beds. Those are reserved for our maternity care. We do utilize those for appropriate issues when necessary. So a female that may come in with a gynecological issue that needs admission, if we need a bed, sometimes if the maternity unit is able to accommodate, we can put those types of individuals on a maternity unit, but they are not considered in our general medical surgical inventory of beds from an operational perspective. Maternity they're not full every day, but we are within our benchmark, our industry best practice benchmark. And again, maternity and the type of care, I have my physician colleagues here to speak more eloquently to it than I can. We need to make sure that we have available capacity within that unit, given the unpredictability of maternity care. Some days they are full, some days they are not. How many of those are staffed? They are, so they operationally are staffed virtually every day fully. So we use every available bed to our patient population every day. Yes, again, is MidState aware that the Hospital Central Connecticut is licensed for beds? MidState aware that HOCC does not utilize all of their licensed beds?
Are aware. I don't think we really should be considering HOCC. We have plans for those beds. Very community we serve with the Hospital Central Connecticut. Long-term plans for those beds to serve the community of.
Discuss that you are filtering some patients, not all, to HOCC. Explain why you're not transferring it. I understand the patient choice, but
Well, it's patient choice. This is if we're transferring a patient to HOCC for neurosurgery, say, they have we don't have neurosurgery at MidState. So we transfer those without fail to a facility that can manage that. But we're talking specifically about patients that have the ability to stay at MidState. That would like to stay at MidState. We pretty much ask every patient that's being admitted. We even try to utilize terminology. They have an elbow and pen. I've used every single term that I can. Try to get patients over there, and patients don't want to go. These American patients, these are Wallingford patients. They're in our community. They want to stay in our community. And they get concerned that family members won't be able to do that. They get concerned that they're going to get hooked into now a system, HOCC, where all of their outpatient services are going to be dictated by that community. It's not a tenable answer to the problem that we have. That said, HOCC is an excellent hospital, and I really do tell people that at all times. The problem is that stay in the community hospital.
Regarding just one of the really tough to the point is we are constantly.
Could you speak up a little bit for me?
We try to get patients to the appropriate levels of care, and sometimes severity of illness will drive where we achieve that. We do firmly believe that care in the local community requires a lot less training. There's always risk when you're handing patients off. So we only do it. So we don't have the ability. A lot of our intention that I tried to go through, really, we're trying to build out in the community that will leverage our very expensive facilities across the make sure we can and not have to continue to ship people from facility to facility. If we don't have to, we're trying to bring the care that so available to us every day. We're transferring patients every day across the system. But, the idea is that why would we move away from what is a high performance on the basis we just don't have the capacity for.
Last question. MidState had any discussions with Harvard Healthcare? Location of some of the sisters.
Yeah, so we're oversubscribed across Harvard Healthcare. There is no reallocation that would make any sense for us. Planning, we're going to get what we do. There's no shifting of that around. That's what we do.
Applicant has testified that have increased. However, on page 252 of the filed testimony, the volume of discharge has decreased under 2,000 2019 to just under 600.
Sure. Patients having a joint replacement. Same hospital, same surgeon, same operating room, same bed. Based on payer nuances, sometimes they're considered an outpatient, and sometimes they're almost identical care. The higher risk patients are inpatient. If they're an inpatient, then they're considered a discharge or transition. If they are outpatient, same surgery, same bed, almost identical care, they don't count. So they're extended stay. They don't count in statistics. Discharge. But they still took up the same bed for almost the same amount of time. It's a payer nuance more than a care. They're still in a bed. They're still receiving care on an inpatient unit, but they're technically outpatients.
a shift from to the lower cost. And it's reflected in the performance that we saw when I described length of stays at the clinic. So as we've expedited taking better care of patients, we're trying to transition out of the acute care because their length of stay is shorter. They're characterized as extended stay, which means we get paid less for those care of those patients, even those rated are the same hospital beds and otherwise, but we can transition them out earlier or open the capacity to reside in a lower cost of care.
This question is, what are the diagnoses in the emergency department that are waiting for admission?
All diagnosed. You know, it's, first of all, we see everything. We don't really get trauma to our hospital, but we see trauma. You know, the things that get admitted generally are infectious etiology, they have operating room, you know, having at our hospital. So it's across the board. Specific diagnosis that the emergency department. Anything specifically, but
Clarify, is the ED becoming busier or is MidState boarding more people because of tight bed capacity?
both.
I have a comment follow-up. Yeah, why don't you finish? Yeah, go ahead.
The patients who are extended stay patients, are they coming in through the ED or are they directly admitted?
The answer is both. The vast majority of extended stay patients are orthopedic patients who are getting a joint replacement, either hip or knee. If you came in with a kidney stone through the emergency department, we're going to the operating room, go from ED to the operating room. After the procedure, if you needed 4, 6, 12 hours to recover, you need an extended stay. So that would be, so they come in through the ED, the vast majority come in for get orthopedic.
Steve Larson, just to clarify, procedures that are being done at the hospital. Just a procedure house labeled depending on the acuity for the procedure.
My last question, what does the community health needs assessment say are the community health needs?
It's much what we see. Cardiovascular disease as being a major driver and organ disease that ends up really impacting you. So why we focus on hypertension, diabetes, two very controllable risk factors that can reduce that burden, and one where we know that it comes out. That's really why we focus our strategy.
So just to clarify that orthopedics not appear in the services.
Yeah, I mean, I think-
Get back to the-
yeah, I mean, I think
don't
things like
remember.
aging and such, we can answer that in the late file if you want. Mhm.
I'm trying to wrap my head around the provided us some about the steep decline. So am I correct that that increase is a lot of what's driving about a 400%?
Some of it, but not, a big number is increasing ED volume. I mean, orthopedic volume takes up one pavilion and is spilled over to a few beds on the second pavilion. For the most part, we're able to manage the orthopedic volume because now 28% of outpatients, so you have your inpatients, outpatients. Now 28% of the outpatients never even go up to a bed. They go home from the PACU. So even though our volume's gone up, it's some of it, but the largest is the ED volume. People coming in with stroke, heart attacks, pneumonia, chronic obstructive pulmonary disease, sepsis. Those are the people who are waiting for beds upstairs that need more beds for them.
As we look at our bed need analysis that we provided in our application, we see that based on our fiscal 22 data, we look at inpatients only, so not considering the extended stay patients that we're discussing, we're at a current occupancy rate of 84%, where industry standard for medical surgical unit is 80%. So even without the extended stay, our utilization and our capacity is at 84%.
Helpful for us. I don't recall seeing it. Already. See the changes in the non-orthopedics related. That's the. Overall. As you know, EPH licenses beds, they don't. And you will have the ability, whether they're oncology beds, then to look at OHS. That way, that's an answer. Be helpful. A sense on a given day, talk about the extended stay, but exacerbating. You have a sense of large number of discharges and much of the hospital volume.
Take that as a link file. The numbers that I believe we submitted are combined, looking at our extended stay and our inpatient volume. What I can tell you is that as we look at those 131 medical surgical beds, and when we consider both extended stay and our inpatient volume, we are at a 90% capacity current state. In 84% capacity when we look, or utilization, I'm sorry, when we look at just inpatient. So we're exacerbating our utilization by another 6% or so, but happy to provide the breakout between inpatient and extended stay.
So just so I'm clear on what I'm asking, of the occupied beds, what percent of those occupants really helpful.
That
I will speak up. Sorry to those who are listening.
We will go through the late files towards the end. So everybody's clear, and then we'll issue that as a separate order probably tomorrow as well.
Mentioned that this HOPD plus extended stay is
Yes.
there a difference in the charges for HOPD plus extended stay?
MidState is HOP. Tradition with extended stay that is in the two different buckets. Extended stay is in the hospital.
You charge the same amount if somebody goes home directly from the PACU or if it's HOPD plus extended stay? Well, I mean, I'm trying to understand, so with the patient, do you book a patient? Is it planned that they're going to have an extended stay? Or is it planned just to do the procedure and then depending on the the clinical circumstances, recovery, we decide if they're going to have it?
Look the case, I think the first decision the surgeon makes is inpatient or outpatient. Outpatient done at the hospital versus, I guess the first decision, am I gonna do it at the hospital or am I gonna do it if I have a ambulatory surgery center? Let's just assume the surgeon decided he's gonna do it, he or she is gonna do it at the hospital. First decision when booking is, do I think this patient meets criteria, is complicated enough, and in my medical opinion, they're gonna stay 2 or more midnights. I'm gonna book that as an inpatient. They're gonna come in the morning of surgery. If they're not inpatient, everyone else is outpatient. They go into surgery, and they may have had conversations with the patient, and in their mind, I think you are low risk, great support at home, healthy other than this joint. I think after 4, 6, 8 hours, I might be able to let you go home. Or I'm a little more worried about you, why don't we keep you overnight? Some of it's a discussion with the patient. So those ones who stay more than 4 hours are extended stay. Some actually just stay in PACU and get discharged 7 p.m., 8 p.m. Most go up to a bed and go home the next morning, early, late morning. So it's really about inpatient versus outpatient. And the outpatient is divided into those that can go home same day versus those that stay overnight. We are industry leading. 28% of our outpatient points done at MidState now go home same day.
So this is not an unanticipated extension of this stay. And four, you know that 72% of the patients that you operate on
Stay in the bed overnight, yes.
stay in the bed overnight. Just to go back, Kim. Is there a charge, a difference in charge between two? Am I in a bed versus those?
Because they're outpatient, this is not my area of expertise.
I-
So maybe
I want to get back to
I
it.
may have to get back to you because I don't want to answer incorrectly.
There's a distinct difference between inpatient and outpatient. Whether there's an additional add-on for that they stayed longer than 4 hours, I'll get back to you exactly what that is. I'm not close enough to it.
What led to the establishment of the impetus fee?
You want to take it? Okay. So obviously, it's important, critical extensive series of procedures that often done in tertiary. Like dialysis. Exactly what. From inpatient to outpatient. Is to enable clergy, alignment around physicians who want to. Often a very expensive proposition for everybody, not always getting the kind of experience people. We anticipated this change in opportunity, and so it is a very organized manner to provide that treatment, allowing us to provide wherever it's complex surgery. The appropriate get those there, but still not enough. Quality. Maximize your patient program, and at the same time lower your population of services more fairly.
The Institute was really a focus on, let me ask you, was the focus on expanding the capacity to do outpatient surgery by establishing the institute?
Really above access, affordability. It's not just one thing. It wasn't that we planned laboratories, so we got to build it. We knew mind functions. It's better as talk about population health, just you got to define what population you're trying to build the program around. We'll focus on it. Even recognition better, tighter, and more efficiently. At the same time, drive up the quality and performance, linking all these things together, not just focusing on the inpatient. How do we build this as an entirety program? So get the right care in the right place at the most affordable option, and be able to do that, make it accessible so that people aren't waiting a long time to get their hips and knees and other surgeries. And the inpatient facility that do for complex, sickest, or complicated. It's not just one thing, it was an entire program. We had to do all of it. You can't just do a part of it.
So I want to ask about the hospital. There are a lot of slots that are not staffed. So I don't. There are lots of excess beds. So help us understand why, given that many of these procedures that are requiring overnight stay are planned, why isn't there an ability to somehow, with two hospitals less than 10 miles apart in the same system, why isn't there an ability to for some of those licensed beds or establish the capacity to do some of the things I'm describing go in advance? Not those facility.
To take the clinical part, the medicine's part, Edward. The care that Dr. Carden have described is highly complex. The partnership between the hospital and the physicians, and it's very deliberate. We want to be the place where physicians excel at their craft, that patients chose to come to because it's a better mousetrap. And we built that at the Connecticut Orthopedic Institute. We don't have that infrastructure at the Hospital Central Connecticut. Physicians Now it was 10 miles or 18 minutes on the Chamberlain Highway. They are committed to MidState Medical Center and what we've built. It starts with the outreach with navigators and education before they even have surgery. We have concierges, and it's an experience to maximize the benefit to the patient and their health outcome. Built at MidState Medical Center. And I could franchise that and I retire, but it's special and it's not as easy as just replicating it somewhere else. It really takes position, leadership and commitment, and the administrative commitment. And, it's not easily replicable. It's really exceptional product that we can deliver jointly with our physicians at MidState. I can't just say, ma'am, you're having a joint. We're a little busy at MidState, go have it at HOCC would not be the same experience, nor would the physicians go.
Most of your,
No, I would say 95% of our physicians at the Connecticut Ortho Institute do not have privileges at potential.
You said you would speak to the clinical component, but you would leave it to someone else to discuss the licensure aspect.
Thank you for keeping that.
My job.
The Hospital of Central Connecticut, while it appear on paper to have a surplus of licenses available, as was previously mentioned, there are plans for future growth and development of HOCC. So I would not consider in our planning process those to be available beds. And HOCC has been growing itself over the course of the last number of years and has its own capacity constraints that we are continuing to work through. So in our planning process, we are not considering those as options to fill this need in MidState.
I want to just give you an opportunity to clarify something that was in response to one of our asked about measures of avoidable patient, how you're coping with it has changed over time. Asked about specific measures, and there are standardized measures of admissions, but avoidable. I think the response was tracking that. And so I just want to give you the opportunity either now or file to share any data that you have.
Please, I just want to clarify. You said, your state level, not that we're quoting.
That was Dr.
Yeah, it's really that we are level. It's actual patients who are kind of being performed. So.
But the data source.
Right. Yes, it's a way
Okay.
for us to track avoidable. So it's our measure to be able to track, are we having an impact on avoidable? So that was really good.
It's essentially saying that the patients that are presented to the emergency department, sicker, require.
In terms of track, there are issues trying to track what you define as avoidable. I realize there are some standards. We are trying to, are we seeing the patients who should be seen in here that that's placeholder we use because we how many level twos are still getting direct strategy for that. There's a but also we follow up with a lot of patients and say, hey, you could have gone to an urgent care center. Here's a location. So we do a lot of work. I understand that there's a host of diagnoses that could have been, some of them that are conditions. That bucket, we follow that in our CHF program, other things to try to manage them more effectively. There are other conditions that are, in retrospect, you say, but chest pain that's very chest. Patients don't. So the data gets a little bit hard to parse out sometimes what the avoidable perspective, or just avoidable to produce that, you really. So all that noise, we try and really focus on a low level for us. It's not that we're not paying attention to it, it's just we don't necessarily parse it out as the way others have defined those moments.
Your mentioned some of the Facebook. Have any data from great standardized markers of a voice? Here.
Yeah, I'll look and see if we can have a comprehensive, pretty much what we're focusing on is too. Have a conversation. And get home as opposed to access and accommodation availability. Change that. So those are the kind of things where we impact our patients to make sure. So it's across our specifically measuring, tracking definition of as I've described. I'll see what our data.
Attorney Fusco, do you need a moment? Or proceed with redirect? Have any questions?
Just give me a minute to see if anyone in the group.
So this time, I think we're ready to, I should ask if you have any follow-up questions on Dr. All right, I should have asked that before. Over to Attorney Fusco. So this time, we're going to take a 15-minute break. We'll come back at 1 o'clock for public comment. Anyone who wishes to speak can sign up through Zoom or and log their name. And
Are you taking a break now until 1?
Welcome back. For those just joining us, this is the second portion of today's hearing concerning a CON application that MidState Medical Center filed. The docket number is 23-32657-CON. MidState seeks an increase in licensed bed capacity. We had the technical portion this morning, and we are now ready for public comment. Afterwards, we'll go through the late files and do some closing remarks, and then we will break. So sign up for public comment has been all day in person and on Zoom in the comments section. If you have not yet signed up, please do. I believe we have one person who has signed up thus far. It's the mayor of Meriden. So we will take him first. Speaking time is typically limited to 3 minutes, but for elected and appointed officials, we generally allow for greater flexibility around that time. And we strongly encourage you and anyone else listening to submit any further written comments to OHS by email or mail no later than 1 week. That is 7 calendar days from today. The email address is concomment@ct.gov. And let's see. Our contact information is also on our website and on the public information sheet that you were provided at the beginning of the hearing. So we are now ready to take public comment. Maida, is it correct that we have one person? Okay.
Okay, can you instruct them to raise their hand? So they can,
If there is anyone else who would like to make a comment, they just have to raise their hand and then we will be able to process them to bring them into the meeting. So I believe we are now ready to allow the mayor of Meriden in.
Can you guys hear me all right?
yes.
We can. We can't see you though.
It's okay.
It is telling me the host has stopped or not allowed me to start a video.
Oh.
So if you'd like to allow me to, I can pop that up for you. Start my video. All right, how's that
There
work?
you are.
All right.
All right. Thank you for joining us.
Absolutely.
So feel free to speak whenever you're ready.
Thank you. And thank you, Dr. Gifford, the entire OHS team for holding this hearing and allowing me to speak. As mentioned, my name is Kevin Scarpati, Mayor of the City of Meriden, home to MidState Medical Center in our city. We've had a great relationship with MidState officials, and really over the last several years, I'm proud of the work that we've been able to accomplish with MidState and their entire team. We've really worked hard to build trust and a great, strong relationship between our community members and our hospital. Unfortunately, when there are times that patients have to remain overnight in the ED after being admitted or are kept for hours on end, as you've heard in some of the testimony earlier today, on beds in hallways in our ED or in the waiting room for hours, or are constantly asked if they would consider transferring to a different hospital due to capacity constraints, that hurts all the work we've done over the last few years to really build that relationship, especially coming off COVID, when we did see a reduction in visits to our emergency department and overall hospital, as many did. So I just want to also share with you a bit of a personal story. And the patient that unfortunately has to seek care all too frequently at MidState Medical Center is my mother. My mother is one that has a lengthy medical history and various health conditions, and relies on us, her family, for not only primary care, but also transportation. And so when she's in need of care, we have to, one, convince her to go to the hospital, which, as you can imagine, isn't anyone's favorite place to go to. But we know in going to MidState, it's a place that she could be comfortable. And I don't just mean comfort as in the bed that she has to lay in, but comfort in knowing that she's in a familiar atmosphere and space. She's going to receive quality care. She's going to be in a quiet and safe setting, all of that with MidState. And then we know that aside from just great care, we're going to receive a comprehensive discharge plan when she leaves the hospital. Unfortunately, in our last visit there, she was one of the many, I'm sure, that had to stay in the ED overnight, her first night after being admitted, because there wasn't space. And then waking her up earlier in the morning to transfer her to a room that then allowed us to go and see her the next day. All of that only hurts if that continues to occur. That frequency hurts not only the work we've done as a community, but hurts the odds of me as her son to convince her to go to the hospital the next time, because she doesn't feel as though she's going to get that same level of care. And all of that really comes down to what you've heard today, the strain on capacity within the hospital. And so I speak to you today not only as mayor of our city, and one that is proud of the work we've accomplished and wants to see a growing facility delivering high quality care, but I come to you personally as someone that relies on the hospital for my needs as well as my family. that we do need these additional beds. We need the additional beds, and I've seen it firsthand, unfortunately, impacting the care it is received my mother. And so with that, I again thank you for allowing me to come on and testify, but also allowing this hearing because it's truly a need at MidState, and to ask others to just treat them as numbers and plug them into a different facility that they're not close with or comfortable with just wouldn't be fair. So on behalf of the entire city of Meriden, I urge you to approve the certificate of need and the expansion of beds at our facility. Thank you.
Thank you, Mayor. Has anyone else signed up, Maida? So we're now going to proceed to discussing the late files. Actually, OHS, did you have any questions based on the mayor's comments?
No, we didn't.
So now we can turn to the late files. There is one document that OHS said it would be providing, and that's the Exhibit C spreadsheet with the sources of the data. We will be uploading that by Monday. And then you'll be provided with ample time to respond, which we can discuss after we've gone through everything else. So the first late file for the applicant is an explanation, and OHS, feel free to jump in whenever you may want to offer any clarity. Explanation of how orthopedic need is tied into the CHNA. That's a community health needs assessment. Number 2 is changes in non-orthopedic admissions volume year over year. In addition to what has already been provided with respect to oncology. And we were thinking 5 years because that would help capture a little bit before COVID as well as current.
Are you looking for us to break down the inpatient admissions, just call out the order?
Sorry.
I apologize. Are you looking for us to break ortho out of inpatient admissions and give you the balance, right? So as you had asked Dr. Gifford, what's the percentage that is ortho admissions? Okay, thank you.
Number 3 is average daily census of maternity beds. Again, 5 years. And we'll issue this as an order also, that way you have it in writing. Number 4 is the percentage of occupied beds that are occupied by extended stay patients. And that again would be 5 years. Number 5 is an explanation of whether there is a difference between inpatient and outpatient billing if staying overnight versus more than 4 hours. Maybe I stated that incorrectly.
I think
Yeah.
so it's HOPD patients. Are they billed differently if they have an extended stay or don't? Okay.
And then number 6 is data from value-based payment programs regarding tracking of avoidable ED visits.
Value-based payment programs or other sources. I assumed that would be where you would be tracking.
Attorney Fusco, did you have any questions on those?
I don't think so, and I think that covers everything I had on my list. No, all set, just timing wise, what works is 2 weeks. Is 2 weeks acceptable to turn it around?
So that would be, let's say, February 9th.
Sure.
That's a Friday.
Yep, that works for us.
Attorney Fusco, would you like to make any closing remarks?
Sure, and I'll keep them brief in the interest of time. I just want to thank you all again today for taking the time to hear our evidence on this very important CON, and we hope that our testimony has given OHS a better understanding of the situation that's facing MidState Medical Center right now and why the addition of 16 licensed beds is critical to the hospital's continued ability to provide timely, safe, high-quality care for all patients. It's this agency's charge, as you know, to look at CON applications through the lens of the guidelines and principles set forth in 19A 639 of the general statutes. And so I just thought I'd briefly touch on a few of those criteria here. First, MidState has shown, unequivocally that there is a clear public need for 16 additional beds at the hospital. And so these beds would not in any way constitute an unnecessary duplication of services. MidState's undertaken a well-reasoned needs assessment that shows the need for substantially more beds than the 16 we're requesting. If you look, there's a range of beds needed for inpatient only and beds needed if you add in extended stay patients, and those far exceed on the high and low range the 16 beds we're requesting. I think we've shown that we have an occupancy rate, even without extended stay patients, of 84%, which is over the 80% target optimal capacity for community hospitals. And if you do consider extended patients, which you have to practically because they reside in inpatient beds and they utilize inpatient resources, then as Ms. Edwards said, your occupancy rate goes up to 90%, which starts to become unworkable and is the reason why you have as much ED boarding as you do. The practice of ED boarding, and remember, these are patients that are in the emergency department for upwards of 2 to 4 hours. They are in hallways, they are in chairs, it compromises care, not just for them while they're waiting for sort of this more focused and coordinated inpatient care, but also for patients in the ED who are looking to come in and be seen in those very, in those very beds and treatment cubicles where these people are. So getting the inpatient beds is going to improve that throughput for sure. The proposed additional beds are also going to enhance access to high quality and cost-effective care for all patients. And that obviously includes Medicaid patients and the uninsured, who comprise, I think, about 20% of the hospital's payer mix. Again, there are clearly issues accessing services if you have patients who are boarding in an ED for upwards of 4 hours. Inpatient beds simply aren't available. These patients who need to be admitted need focused, coordinated, longitudinal care, which they just cannot receive in the emergency department from the emergency department staff that, is not an inpatient staff. And while those ED clinicians are trying to treat emergency patients. You've heard everyone testify what we've done to try to improve throughput, to try to reduce length of stay, to try to reduce 30-day readmissions, and ensure that patients are not utilizing inpatient beds or resources for any longer than they need to. I mean, every effort is made by this hospital and all system hospitals to reduce length of stay and ensure that patients are getting the care they need, but not staying in the hospital any longer than they need to. And all of those efforts have helped with this issue and made it so that, things aren't completely untenable, but still the boarding is happening and the capacity issues are persisting. Adding licensed bed capacity with everything that's been done to try to correct this problem is really the only way to fix it, right? Everything else we're doing is just putting a Band-Aid on a problem that's going to continue to get worse. Adding that bed capacity is going to bring immediate and meaningful relief, not just to the ED patients, but to the admitted patients as well. We've talked a little bit today and in our testimony about how the issues with ED boarding and delayed care for admitted patients raises quality and safety concerns. ED boarding obviously risks adverse outcomes for admitted patients. It's detrimental to the quality of care that people are getting in the ED. And when you add these beds, you're going to substantially decrease the amount of time that these people are waiting. You're going to get them where they need to be, and you're going to free up so that they can get the care they need, and you're going to free up the capacity in the ED so that staff can focus on emergency patients. And getting patients that timely care is also cost effective, right? Delays in care or elopement. One of the witnesses today talked about patients leaving without being seen, whether they're ED patients or admitted patients. These are patients that need to be seen, and there can be, substantial adverse consequences if someone leaves the hospital without being seen, particularly someone who needs to be admitted. And as those consequences play out, those are things that can drive up the cost of care. And also you heard, you know, from a cost perspective, Dr. Engelberg testify about physician attrition. It's not easy to replace an ED doc who leaves because the boarding situation is not something that they can handle, or an ED nurse. And so you avoid those costs too if you free up that capacity in the ED and let them do their jobs. If you look, you'll also see that the proposal is consistent with the guiding principles in the statewide healthcare facilities and services plan, which, you know, is an advisory document that includes non-regulatory standards and guidelines. I mean, similar to what you're looking at in decision criteria, it ensures overall access to quality healthcare. It promotes equitable access to services. It facilitates access to the appropriate level of care in a timely manner. That's probably the most important. And it just improves the overall quality of healthcare services available for state residents. Staying with the state health plan, in evaluating bed need, you know, we used our own bed need model, right? And it's a model that's sensitive to the unique circumstances at MidState, and it accurately reflects the patient populations, which we've talked about today being, you know, unique and different than some hospitals, services, staffing, and just the dynamics at MidState that impact their inpatient bed capacity and throughput. The population-based methodology, which I know we're going to get to comment on, is not an appropriate measure of bed need at MidState for reasons that we've discussed. I mean, it's a population-based model that looks only at New Haven County. And we can tell you that patients come to MidState, you know, for the COI and other reasons from other areas of the state. And it doesn't, that you use a weighted ADC from 3 years prior that covers the COVID years, right? So it's not looking necessarily at the years where you're seeing tremendous growth in inpatient utilization of beds. And I think the biggest issue with that methodology is it doesn't acknowledge that there are factors other than population growth that can move average daily census, right? It gives you an ADC and it says if the population is growing, the ADC is going to grow proportionate, and that oversimplifies things. There are a number of factors, including sort of the specialization of services we've talked about at MidState that can move and have moved ADC tremendously at MidState over the years. But if you do look at the other factors listed in the state health plan that you can and should consider in bed need CONs, I think all of them are relevant. One of them refers to observation beds. We consider our extended stay similar, right? Extended stay patients are taking up inpatient resources and they need to be accounted for. The hospital has had, I think, at least 3 months over the last 12 months where they've exceeded 80% of capacity for a period of more than 30 days, which is one of the factors. The plan also lets you look at particular innovations in healthcare and the change in care delivery to treat specific diseases and conditions, which is exactly what the Connecticut Orthopedic Institute is. And then lastly, and probably most important, it lets you look at patient quality and safety concerns, which we've talked about a lot. So we would ask that you consider those other factors, that you consider the alternate bed need model. I know we've administratively noticed some other CONs where this agency has looked at requests for beds or facilities that were modeled differently than the state health plan population-based model. And, you know, there are different ways of doing this, and that the agency has acknowledged that. And finally, I think in terms of utilization of existing providers, there's sufficient demand in the MidState communities to support the requested beds. You know, beds are needed to treat patients who choose to obtain their care at MidState, who need the specialized services that MidState offers, you know, whose treating physicians don't have privileges elsewhere. We talked about that with respect to the COI. Like, the demand exists at MidState kind of independent of any other hospital's bed capacity. And I think you know, we talked a little bit about HOCC, like, another hospital's beds are not the solution to this problem. Like, those hospitals' licensed beds are intended to treat patients in that community, right? They are allocated for that community. They will be staffed for that community when they can. We need beds to treat the issue at MidState and to care for patients in the MidState community. So with that, again, I thank you. I think that when you look at all the evidence we have established, you know, that we've met all the decision criteria. I think increasing capacity is going to improve throughput. It's going to stabilize the hospital's occupancy rate. It's going to reduce the number of patients boarding in the ED and ensure that all patients have timely access to safe healthcare. And so for those reasons, and we would ask you to approve our CON request. And thank you again for the time today.
Thank you, Attorney Fusco. I have nothing further. Dr. Gifford, did you want to make any additional
No,
closing remarks?
thank you for your testimony. We appreciate it. And thanks for your patience and thanks to the public for your patience with our technical issues today.
And thank you to the witnesses as well, if they're still over there. All right, so we'll issue an order with the late files and we will proceed in the normal course as we normally do.
All right, thank you so much.
You're welcome.
Thank you.